Good afternoon, everybody. Welcome to our Heart Health lecture series. This is American Heart Health Month, and we have a fantastic talk this evening, which we're calling Heart Health Matters, Managing Your High Blood Pressure for a Healthier You. Next slide. So I am Dr. Dennis Goodman. You all know me very well. We've been doing this for 10 years now. I'm very grateful to Anya, who helps me put on this series. And as you all know, we have many of you who tune in regularly, and we've covered many, many topics specifically related to prevention and being healthy. So I'm a clinical professor in the Department of Medicine and Director of Integrative Medicine at the Leon H. Charney Division of Cardiology, and I'm part of the Center for the Prevention of Cardiovascular Disease at the NYU Grossman School of Medicine. Next slide. So welcome. I just wanted to again tell you that if you have any questions, we've already received many questions, but if you have a question while the talk's going on, if you just go to the Q&A box and you put in the questions, I'll be fielding them and we'll get to as many questions as possible. Next slide. So there are a couple of upcoming webinars. We always like to let you know what they are. I'm very excited because on Tuesday, March 25th, we have a webinar titled Artificial Intelligence, AI in Patient Care, from Diagnosis to Recovery. Please put that in your diaries. Next slide. On Monday, April 7th, we have Exercise for All Ages. Next slide. So to access our video library, we're very happy to tell you that many of our talks are now on YouTube. You can access these talks, or for example, tonight it'll be recorded if you want to listen again or tell your friends about it. The website is nyulangone.org/hearthealthlectures, or you can take a picture of this QR code. There's another email down there if you want to be notified by email when a new video is posted, and that's hearthealth@nyulangone.org. Next slide. So keep connected, and if you want to stay connected, there's our website, our email, and Instagram, and Twitter. Next slide. So as I said in the beginning, February is American Heart Month, and the American Heart Association's Go Red for Women. So we always choose very carefully in February. We like to have somebody that's very focused on cardiovascular prevention for men and women, but with very specific focus on the fact that we are aware of how important it is for women to know about their cardiovascular risk. And maybe Arthur will say something about that, Dr. Schwartzbard. Next slide. So it's my great honor and privilege to introduce Dr. Arthur Schwartzbard. I consider him a friend. He's a fantastic cardiologist, and he is a board-certified cardiologist who completed his cardiology training at NYU Grossman School of Medicine. He's a founding member of our Prevention Center. He specializes in preventative cardiology and plays a key role in training future physicians in the field. Dr. Schwartzbard is actively involved in clinical research. He maintains a thriving clinical practice at the Prevention Center and also sees patients at the Tisch Men's Health Center. Could you go back one slide, Anya? No worries, not to worry. I just wanted to say that Dr. Schwartzbard is an associate professor of medicine. He's also the program director in Preventative Cardiology Fellowship Program. He's a clinical research director for the Center for Prevention of Cardiovascular Disease. And Arthur, you are beloved by the patients and your colleagues. It's a great honor to have you, and thank you for coming to do this talk for us tonight. Over to you, and don't forget to share your slides.
Okay. Let's share. Anya, maybe you can tell me if you're seeing.
Oh, yeah, I just want to go up to your first slide, that's all.
Okay. Maybe I'll just ask you to advance, Anya. I'm not able.
Oh, okay, you know what? So then if you could stop sharing, I will go ahead and share your deck on my screen.
Okay, okay. Okay, so thank you, Dennis, for a kind introduction, and thank you, Anya, for all your help with slides and preparation and all you do for our prevention program. Dr. Goodman is very humble, but he's done a lot for our prevention program, and I appreciate the invite. It's an honor to speak with all of you who are tuning in tonight, and happy to field any questions after this is done. This is my outline for tonight. What's blood pressure, why it's important for heart health, a little bit about the current blood pressure guidelines and what they recommend, a little bit about medications and what's effective, how can I prevent complications from uncontrolled high blood pressure. I spend quite a bit of time in my practice talking about lifestyle changes and non-medication alternatives, and finally, a little bit about monitoring at home. Next slide. So let's start at the beginning, a little bit about blood pressure and why it's important for heart health. Next slide. Here we go. So this is from the Heart Association, and here you see all the reasons why we're interested in blood pressure. Hypertension or high blood pressure can cause stroke, heart failure, sexual dysfunction. It's linked to heart attacks, kidney failure, loss of vision. I think those 6 reasons from the Heart Association are more than enough reasons to be strongly interested in blood pressure and how to protect against it. Next slide. This is data from Lancet, the English journal. And here what you see is, from one of our hypertension journals. Here what you see is for every 20-point rise in the upper number, what we call the systolic blood pressure, or 10-point rise in the diastolic blood pressure, there's a doubling of death from both ischemic heart disease and stroke. So I will try to make the case to you tonight that the curves actually go in both directions. That is, higher blood pressure associated with higher risk and higher mortality. And as we lower blood pressure, thankfully, we can greatly reduce that risk. Next slide. So most people, we don't find a cause. Patients come in expecting that their doctor is going to reveal why they have hypertension, but it turns out almost 95% or so of people with high blood pressure just have it. The books call it essential hypertension, as if it's as commonplace as air or water. So common is hypertension. And it definitely increases as we get older. And there are, though, some very high-risk groups. So African Americans have a higher incidence of developing hypertension. Men are a little bit more likely than women, although women catch up to us after menopause. About 5% of the cases are what we call secondary hypertension that actually do have a cause. And I'll talk about that at the end. Next slide. So first, a little bit about high blood pressure and heart failure. And it turns out that many trials have shown a very clear association between having high blood pressure and developing heart failure. And just having hypertension is responsible for 1 out of 4 cases of heart failure. So I put just in quotations, but as I'll show you in a little bit later, a landmark trial called SPRINT demonstrated that there was a reduced risk of progressing to heart failure in people who had more aggressive control of their blood pressure. In this case, a blood pressure of 120, the upper number, the systolic, versus 140 in the less well-controlled. Next slide. So how do you get your blood pressure checked? Well, a lot written about this. Ideally, you sit still, at least for 5 minutes before your blood pressure is taken. We try to get people not to do it right after they exercised or had coffee or smoked. Hopefully, they're not smoking at all. And really, in the 30 minutes before, it'd be nice that there's a calm environment. If you check blood pressure while you've just been exercising, your blood pressure rises with exercise. As people get older, or if they have other diseases like Parkinson's or other what we call autonomic diseases where blood pressures can be very different sitting versus standing, we'll ask them to also check blood pressure standing. More on that at the end. During the time you're inflating the cuff, again, you're supposed to sit upright, the back straight, feet flat, try not to talk. And we ask people to do several readings. Many people are nervous when the first blood pressure reading is done. So we ask them to average the readings and frankly, show us their log, show us what they have for the blood pressures. Of course, we measure blood pressure both in the office and at home, and we'll talk about that more in a moment. Next slide. So this home versus in the office has turned out to be very, very important. there is a group of people who have what we term today white coat hypertension. That is, when they're in the office, they're nervous, they're in front of a doctor, and the blood pressure's high just because they're tense and things like that, and have catecholamines, the hormones released that raise their blood pressure. But yet, those people, many of them out of the office, are normal. When they're not around some doctor in a white coat like me, they may be totally normal. But there's another group that has what we call masked hypertension. That is, in the office, they're normal, but at home, they're high. And as I'll show you, the second group, the masked hypertension, is the group that we're really focused on. That's the group that's really at increased risk for the things we spoke about earlier: stroke, heart failure, heart attack, etc. Next slide. So what do the current blood pressure guidelines recommend? And here's one of the landmark slides. I asked you, if you're reviewing this afterwards, to go back to this. This is a bit of a sea change. Most of us grew up in a world where hypertension was you had a blood pressure of greater than 140 over 90. And now you can see that the guidelines call a normal blood pressure, shown here as normal BP, as less than 120 over 80. And if you're less than 120 over 80, they recommend just healthy lifestyle and just check annually. They already call you elevated. Elevated blood pressure when your upper number, your systolic, is between 120 and 129, or while your diastolic is less than 80. And at that point already, we're talking about lifestyle changes and reassessing in a short time, in just 3 to 6 months. And it's called stage 1 hypertension when your upper number is 130 or higher, or your lower number is between 80 and 89. And at that point, we're supposed to assess your risk. If your 10-year risk, and there are risk calculators that are free online, if your 10-year risk is greater than 10%, you're not only supposed to be doing lifestyle changes, but you're supposed to be starting medication. And that comes as a shock to many patients, that we're interested in using medications in people who either have heart disease or at high risk for heart disease much sooner and at numbers that they didn't consider so elevated. And not only do we start the medicine, but we reassess. And if they're not a goal, we intensify. And of course, a stage 2 patient is already greater than 140 or a diastolic pressure greater than 90. And then we want to do not only lifestyle changes and drug therapy, but we have to reassess and, again, hopefully assure adherence. The numbers of people who are given blood pressure pills and don't take them, or fall off of them, or just don't want to take them, is extraordinarily high. In some studies, it approaches 1 in 2 people. So the adherence becomes really important. It's not enough to just get started. We want them to stay on the medication and to stay on the lifestyle changes. Next slide. These are some of the lifestyle changes that have been suggested. Of course, physical activity is very essential. We're trying to get people to do 90 to 150 minutes a week, try to get their heart rate up, dynamic resistance training, bands, lightweight, are all encouraged. All of these have been shown to lower blood pressure. Isometric resistance training, where you hold a hand grip and you do several sessions a week, all have been shown to help lower blood pressure. So why not take full advantage of that? Healthy diet. We're going to talk a little bit later about the DASH diet, which is high in fruits and vegetables and whole grains and low-fat dairy and cuts down on salt and things like this. Quite dramatic, impressive results. Blood pressure can go down as much as 11 points. So again, we want to maximize that. Of course, body weight's key. Reducing salt is key. Enhancing dietary potassium. And also don't want to leave out, and we'll touch on it at the end again, there's quite a bit of data to show that if you moderate your alcohol consumption, that your blood pressure comes down. Next slide. So although we're talking about drugs today a little bit, I don't want you to forget about the importance of lifestyle change. So what do the guidelines recommend for initial choices? And there are really a couple of drug classes that are popular. One is the thiazide diuretics, which were formerly known as water pills. Second are the calcium channel blockers. And then are the renin-angiotensin drugs. Those are known as ACE inhibitors or ARBs, and you'll see some examples of those in a moment. A single drug is reasonable when patients stage 1. That's the 130 and up. And then can titrate the dose, or you can add additional drugs. And the guidelines recommend that you give 2 drugs, 2 first-line drugs from different classes, either separately or in a combination, whenever there's stage 2 hypertension or the blood pressure is more than 20/10 above the target. So it's not unusual these days for a patient to come to a doctor and be started on a single pill that has 2 drugs in the same pill. Next slide. These are some examples. This is data from the European Heart Journal a couple of years ago. And you see some of the popular single pill, one pill shown in green in the slide, but yet it's a combination. It's an ACE inhibitor or an angiotensin receptor blocker plus either a calcium channel blocker, shown here as CCB, or a diuretic. And then lots of different combinations. They're triple therapy where people get 3 drugs in one. And for patients who are really resistant, often a drug called spironolactone is added, sometimes an alpha blocker or a beta blocker or other drugs. And hypertension experts start to get involved when blood pressure is very, very difficult to manage. Beta blockers, which when I was a cardiology fellow were front line, are now most commonly used in people with either heart failure or coronary disease or atrial fibrillation, much less commonly used in just routine hypertension. They're also used in the pregnant population as well. They have good safety data in pregnancy. Next slide. So there are some other considerations. I'll just touch on them briefly. What about race and ethnicity? So there have been a lot of trials looking at different ethnic populations. It's worth noting that in Black adults with hypertension who don't have heart failure or chronic kidney disease, including those with diabetes, that an initial blood pressure regimen should include a thiazide type diuretic or a calcium channel blocker, that population responds well to those particular classes of drugs. Next slide. So which medications are most effective for blood pressure management? And it turns out that not all of these drug classes, even drugs within the same class, as I'll show you in a moment, they're not all the same. So here are some examples of thiazides or so-called water pills, thiazide diuretics. Common examples include drugs like chlorthalidone or hydrochlorothiazide, indipamide, and common examples of angiotensin receptor blockers or ARBs. And there's several of them listed here, 7 of them listed here. And you would think, well, they're from that class, they'd all be the same, but as it turns out, they're actually quite different. Next slide. So here's an example comparing hydrochlorothiazide to chlorthalidone in a trial that I won't show you tonight. Chlorthalidone was used in a trial called SHEP, systolic hypertension in the elderly, and it dramatically cut stroke. And here you see in a combination between the stippled line and the solid line that the chlorthalidone group had better reduction in blood pressure. And so more and more we're seeing that this particular diuretic used over hydrochlorothiazide. Next slide. Here's an example of different ARBs, different angiotensin receptor blockers. One called azilsartan and one called valsartan, 2 effective drugs, but yet differences in the degree of blood pressure lowering. In the bottom red and green graphs, you can see a larger reduction in systolic blood pressure when azilsartan, which was known commercially as Idarbi, was given rather than high dose of valsartan. So although all the drug classes are effective, there are differences within the different drug classes. And of course, if you're trying to minimize how many pills a patient takes, we'd like to use the most effective of the drugs. Next slide. Okay, so how can I prevent complications from uncontrolled high blood pressure? Next slide. Well, this is really the trial that really launched a big change, a sea change in national guidelines, and that's a trial called SPRINT, which is abbreviation for Systolic Blood Pressure Intervention Trial. And it really showed that treating systolic blood pressure, again, the upper number, the systolic blood pressure, the levels that were far below where we were previously doing was associated with quite a bit of benefit. Next slide. So SPRINT recruited over 9,000 people over the age of 50 at increased risk. They had an average blood pressure systolic, again, the upper number, between 130 and 180, and they're randomized. Should I try to get them below 120, the upper number? That's the intensive group. Or less than 140, the less intensively treated group. And the primary outcome was the cardiovascular disease composite of heart attack, stroke, coronary syndrome, heart failure, and death. And the people in the trial were asked to use regimens based on the best evidence, but the ultimate choice was made by the physician site investigators. Next slide. And the principal finding was that the trial was stopped because there was a huge benefit. So that is that the group, overwhelming evidence of benefit in the group that was treated more intensively. And again, many people, when they see this data, they're surprised. This is a target of less than 120. This is intensive blood pressure regimen. And the primary outcome was lower, was significantly lower in the group that was managed more aggressively to that lower target. Next slide. Here's the graph from the New England Journal of Medicine, and here you can see the curves. There's a pretty large separation, hazard ratio much higher for people on standard treatment. Many people come thinking, oh, I'm 140, I'm not so bad, but as I've showed you earlier, that's stage 2 hypertension, and intensive treatment clearly reduces risk. Next slide. Well, let's go through some of the outcomes briefly. The primary outcome and all-cause mortality were lower. So 25 and 27% lower in the intensive group, and that included 43% reduction in cardiovascular death and 38% reduction in heart failure. So intensive treatment also reduced the risk of the heart muscle getting thick. That's what we call target organ damage. And it resulted in greater thinning of that muscle. So if the muscle was already thick from high blood pressure, it got better. So these were the kind of outcomes that really matter. This isn't just you feel better. This is less death, less cardiovascular death, less heart failure. Next slide. And, this is really, obviously, this is the number one DRG, number one diagnosis code in the United States is people coming to the hospital with heart failure. So this is a very meaningful endpoint. And in fact, it's not unique. Sprint experience has been duplicated in other hypertension trials. There's a trial called HIVIT, high blood pressure in the very elderly, 64% less heart failure. SHEP study that I alluded to earlier, treating with a water pill, a diuretic, chlorthalidone in elderly, 50% less heart failure. And in the CIST-UR trial with a calcium channel blocker, 36% less heart failure. So these are really meaningful endpoints. And again, and I would ask our audience to really keep these numbers in mind, that intensive lowering is actually quite protective. Next slide. Well, stroke was not significantly reduced, but intensive ARM led to significant reduction in what's known as cognitive impairment or mild cognitive impairment. And certainly we get a lot of people wanting to avoid cognitive impairment as they age and probable dementia. And so that's an endpoint that we consider meaningful as well. Next slide. What about adverse effects? Doctor, is it dangerous for me to get my blood pressure too low, less than 120? Isn't that too low? Well, there was an increase a slight increase in adverse events, serious adverse events like low blood pressure. But the differences for passing out, what we call here on the slide syncope, or falls, were not significant between the two groups. And so therefore the argument would be that you'd want to at least try to lower the blood pressure as much as you can, so much as the patient can tolerate. Next slide. So for adults, the recommended goal for patients with hypertension, for adults who have confirmed high blood pressure and known risk, either proven heart disease or an increased risk by a calculator, a blood pressure less than 180 is recommended. Now, I just showed you data of less than 120. We'll touch on at the end why the guidelines left it at 130. In the trial, they left people alone, unattended, dark room. The national guidelines felt that isn't the common way that blood pressure is done, and so they left the target at less than 130. And for adult, but for even that, it's confirmatory evidence that lower blood pressure is better, less heart failure, etc. For adults with confirmed hypertension without risk, again, target of less than 130 over 80 is likely reasonable. Next slide. How about the lifestyle changes? And a lot of people, of course, want to know more about that and non-medication alternatives. So again, I remind you of a slide I showed you earlier. Anything I show twice, I always tell our faculty and students, it's something that I really want you to take home. This would certainly be one of them. We want the exercise. We want the 10,000 steps, etc. Dynamic resistance training. We want the DASH diet, healthy weight, less salt. Dietary potassium seems to be protective, and we want much less alcohol intake. Next slide. Well, here's some of that data from the DASH diet. About 460 people with high blood pressure, both high systolic, diastolic after just several weeks of being fed a controlled diet, but was mainly fruits and vegetables and low in dairy, fat content. Diets that were rich in fruits and vegetables and low fat dairy and low in saturated and total fat did very well. Next slide. Here you see the reductions. They're quite meaningful. So people ask, can diet improve blood pressure? The answer is a solid yes. And this is a diet that's time tested, much like the Mediterranean diet in many features, but nevertheless, a diet as shown in the picture, high in fruits and vegetables, can really protect. Next slide. We want to, for those who have high blood pressure, we want to reduce their salt intake. I know this has been controversial in the past. It really isn't today. We want to increase their dietary potassium, get them to lose weight, increase their physical activity, moderate the alcohol, all the points we've already touched on. Next slide. This is an example of the plate of somebody with a DASH diet and healthy blood pressure. And I know that many of our patients are increasingly tilting this way, trying to eat more fruits and vegetables, etc. Next slide. Well, the salt is a hard one. Certainly people eating out, salt intake is quite high in restaurants and things like that. But if you compare people on different sodium intake levels, low here being less than 1,500 milligrams a day. So we want to encourage the audience, read the labels, check how much salt is in the product. Next slide. And those who cut their dietary salt down had blood pressure reductions. You pair that with a low salt diet together with the DASH diet is even more beneficial. So is there room for non-drugs to help improve blood pressure? Absolutely. Next slide. Alcohol one, we meet more and more, and we're trying to get people, compared to people who never drank, people who drink moderately had much increased incidence of stage 1 and stage 2 hypertension. And heavy drinkers, more than 14 drinks a week, odds of blood pressure being high and weight being high, et cetera, really high. This is a hard one for people. We're not here to be the Debbie Downer, but we do want for people who are worried and concerned about their blood pressure to reduce their alcohol intake. Next slide. There's very strong links between obesity and diabetes. There are very strong links between obesity and hypertension. Here you see one slide that's compared as your weight goes up in different ethnicities, a very clear increase in incidence of diabetes. And as you know, diabetes is a major player in heart disease. So we want to encourage people to try to get lean. Next slide. And the data on obesity and hypertension, risk of comorbidities, very, very clearly linked to BMI, to body mass index. And so people in the normal weight zone are much lower risk. As weight rises, blood pressure tends to go with it, just as diabetes risk goes with it. So again, we want improvement in that area. Next slide. The Nurses' Health Study also looked at how much sleep a person gets. And the better quality of sleep and the better duration of sleep was a much lower incidence of risk of developing hypertension. We're trying to get people to turn off the tube and actually just get a good night's sleep. Next slide. Here's yet another. This has been studied numerous times. This is from the American Journal of Nephrology. And as people's sleep duration improve, you can see a significant improvement in blood pressure control. Next slide. Monitoring blood pressure a lot of different ways. Next slide. So we already mentioned that there was white coat and masked hypertension. And of course, that means there's office measurements and there's home measurements. And I discussed with you earlier, the masked hypertension group was a group that had normal blood pressure in the office, but was actually high at home, and they were at increased risk. So obviously the role of home monitoring has increased. There is a third way to monitor blood pressure, and that's one of the ways I'm involved here at NYU with 24-hour ambulatory blood pressure monitor, or ABPM. All of these can help. But we strongly encourage the home blood pressure monitoring and the 24-hour blood pressure monitoring as ways to fill in and unmask so-called masked hypertension. Next slide. So if you go back to our guidelines, and again, this is a slide I showed you earlier, we want non-pharmacologic therapy, and it's highlighted here because I think it's not used enough. That DASH diet, the better sleep, cutting alcohol, the weight training, the exercise, all of that taking place virtually at every stage. But we don't want people to skirt away from drug therapy when they are already in the stage 1 and stage 2 category. Next slide. So I mentioned this earlier that even though Sprint had a target, an intensive target of less than 120, that the guidelines left the target at less than 130. And the perception was that the way they measured blood pressure in Sprint trial was a little bit different because it's some unattended readings. And it turns out that only fewer than 50% of the Sprint participants actually had unattended readings alone during rest and blood pressure measurement time period. So obviously the lower the better, so long as the patient's tolerating it. Next slide. And of course, it's know your risk. So the group that has atherosclerotic, or shown here in bar 3 in the recommendations as ASCVD, it's a group who has known heart disease or at high risk. That's a group that should be starting not only lifestyle changes, but starting drug therapy early. And at every one of those stage 1 and stage 2s, it's not a goal. Initiate drug therapy and don't be shy. Get that to goal. That's what Sprint, that's one of the big messages from the Sprint trial and others, like SHEP and others that we mentioned tonight. Next slide. People with stable ischemic heart disease also benefit from blood pressure lowering. There are some drugs that have some compelling indications. I mentioned beta blockers earlier for those with a prior MI or stable angina. There are some calcium channel blocker indications for those with coronary vasospasm. People with reduced ejection fractions or squeeze of the heart can benefit from certain drugs like mineralocorticoid receptor antagonists. And those also will help lower blood pressure, but there can be compelling indications that lead a doctor to write one versus another. Next slide. The diabetes population is a big focus of ours. And all the first-line agents help, but patients who have diabetes and high blood pressure, ACEs and ARBs, especially when people are spilling some protein in the urine, ACE inhibitors or angiotensin receptor blockers are strongly indicated. Next slide. There is a lot of data looking at this diabetic population. I didn't highlight it, but Sprint, that outcome trial I showed you earlier, really is in non-diabetics, but it did include people who have what we call today pre-diabetes. Sugar is a little abnormal, but it's not quite in the diabetic range, and they benefited as well. And the 2019 ADA guidelines endorsed, the lower targets in diabetics who had a 10-year risk that was greater than 15%. Next slide. Well, there's more. I don't want to leave the audience missing out. This is a slide from one of the medicine textbooks, and it's in a 1 million patient study. I don't think you'll ever see stuff like this replicated. It's an analysis of 61 prospective studies. Look at the link between high blood pressure and age. And you see on the left, coronary disease mortality, of course, rising as people get older. Stroke mortality rising as people get older. For the same blood pressure in an older population, increased risk. But so age is definitely a factor, but it's not the only factor in control. Next slide. And then there's all these secondary causes. So I mentioned at the beginning that 95% of the time we don't find a cause, but 5% of the time we do. This is taken from one of the medicine textbooks. Here are some of the examples of actual causes that, if remedied, can correct blood pressure. And in that 5% of what we call secondary causes of hypertension includes the most common, which is kidney disease. That can be found with looking at the urine, the kidney ultrasound. There's something called renovascular disease where the blood supply to the kidney can be off. There's a disease called primary aldosteronism where patients present with a low potassium and very refractory to control blood pressure. And of course, we think of the secondary causes of hypertension in anyone who has a very difficult time getting blood pressure to control. Cushing's syndrome, which is a cortisol-related disorder, can cause, there's some clues to that. People have truncal obesity and they have some abnormal blood test. There's a disease called pheochromocytoma that has clues shown in this table, spells of blood pressure, pain in the head, sugar problems, palpitations, and that leads to certain blood testing, checking for those hormones. And people with sleep apnea who snore a lot at night or have a large neck, etc., should get a sleep study. These would all be in the list of common causes of secondary causes of hypertension. And lastly, mentioned in the table is another vascular disease called coarctation of the aorta, a narrowing of the aorta, difference in blood pressures between the arms and legs, and can be found with an aorta picture. Next slide. So I'd like to close with a summary. We believe very firmly that hypertension is a leading risk factor for cardiovascular disease, including heart attack, stroke, heart failure, and atrial fibrillation. There are lots of different medicine categories that can help define treatment. Treatment includes both drugs and non-pharmacologic therapy. We talked about moderating alcohol and trying to get to a healthy weight, improving sleep, and really adhering to the regimen, both to the non-pharmacologic regimen and to the pharmacologic regimen. Of course, we think it's best if medicines be once a day because it's just easier to remember, but these are really the key essentials going forward. Next slide. So with that, I'll stop and hand it over to Dennis and try to field questions. And thank you for signing in tonight and for watching our presentation. I hope I didn't go too fast for you.
Arthur, that was fantastic. Thank you so much. You covered it beautifully. You made the most important point, which is lifestyle changes make a huge difference. And lowering blood pressure is just one of the benefits of many of lifestyle changes, including a healthy diet and exercise. So I've got a lot of questions for you. I'd like to just emphasize two things that you said, because I want to, make the point that alcohol is a risk factor for high blood pressure. And I've had many patients who, when I've managed to get them to cut down or stop alcohol, their blood pressure comes down. Mm-hmm. And so, people sometimes think that alcohol, well, it's a vasodilator. That's why you get red-faced. And so why is the blood pressure going up? But in fact, alcohol also increases cardiac contractility. And that's the way that it raises blood pressure. So let's never forget, and I want to point out to people that if you have a high blood pressure issue, sometimes it's just a matter of cutting back on alcohol or stopping it completely. The other thing I thought that you mentioned is just to remind people that we see people with high blood pressure, and a lot of times they've actually got sleep apnea, especially when they're overweight. And you mentioned this, that it's really important to screen. And I just don't think we do enough screening for sleep apnea. If you're snoring or getting tired during the day or you have high blood pressure, speak to your doctor about getting screened for sleep apnea, because if you treat that, you may not need lifelong blood pressure medication. So I wanted to make those 2 points, and now I've got a lot of questions for you. At what age should you worry about your blood pressure if your heart is healthy?
So the national guidelines mostly are written, pediatricians check blood pressure in younger age groups. Our practice usually sees people from the age of 18 and up, and most of the guidelines have been written for age 20 and up. But really, blood pressure is important throughout your life. And to the question, I don't know who wrote it, but the question about if your heart is healthy, well, we're making the point tonight that one of the ways to keep your heart healthy, one of the best ways to keep your heart healthy, is really to control your blood pressure throughout your life. And like the other risk factors, there's really a gradient of risk. And I think you're seeing that in the trials we touched on tonight. That is, the better control looks to the eye. You say, well, less than 140 versus less than 120, is that going to make that big a difference? But look at the outcomes that we saw in SPRINT. Big reductions in heart failure and cardiovascular death. So these are endpoints worth fighting for. And so, we want to start early, and we want to not only start early, but continue to go after people even in the older. I mentioned a HIVET trial that New England Journal of Medicine published in people over the age of 80. They used to say, wow, people are over the age of 80, do we still have to worry? You not only have to worry, it's a major player in stroke and heart disease. So yes, we not only want to worry, but we want to treat it. We want to control it.
You know, Arthur, I'm a little older than you, but I was at medical school. I'm talking about in the 70s. We were taught that if you were 80 years old, you could accept a systolic up to 180.
Right.
In other words, 100 plus your age. And it just shows you how we've come a long way in understanding that was one of the reasons that people were dying at a younger age.
Right.
And
People
that you've got to get the
sorry.
blood pressure down.
Yeah. People used to be taught that, well, you get older, your blood vessels
Right.
are firmer.
Stiffer.
And so when the blood pressure cuff is inflated, it won't, going to get a higher
Yeah.
reading. And then that was all shattered by the SHEP trial, the systolic hypertension in the elderly that I referred to earlier, where a simple diuretic dramatically cut stroke and heart failure. And then the Europeans redid it with a calcium blocker and very similar results. So lowering blood pressure in the elderly really helps, and it's not something that should be neglected.
And I just want to say, Arthur, that's such a pleasure to hear you referencing the studies and how important they are. We proud that we practice evidence-based medicine.
Right.
And when you do that, you learn a lot. When you understand what the studies are telling us, you did a beautiful job of presenting the important studies tonight. What about stress, which is a huge thing? And I spoke about sleep apnea, but if your blood pressure is very high when you're stressed and normal when you're not, do I need to be on a medication for hypertension?
Yeah, so that's a hard one. That's part of, I alluded to earlier about the different ways to measure blood pressure. One of the
To
Oh, there we
okay,
go.
good.
Okay, we're back. Hopefully we didn't lose you.
My apologies. I don't know if something happened with my
No worries. Can we put the questions back up, Anya? Okay, so
Anyway, we were talking, Dennis, about before we got cut off about stress. Now, obviously, there is some data on different stress relieving therapies. I think some of the non-pharmacologic therapies can be a huge help there. So exercise, for example, can help relieve stress. And so that's a place where the non-pharmacologic treatments can have a big impact.
yeah.
And there are some people who stress is a player, and their blood pressure, and of course, should be addressed.
I think home blood pressure monitoring is so helpful. The people come in with a high blood pressure and they say, well, it's not high when I'm at home. And we check their home blood pressure and we find out that, yes, there's stress when you're driving, there's stress when working during the day. And it's very helpful to see what the average blood pressure is and what kind of spikes they are. And if your blood pressure is getting low when you go to sleep, which is what it's supposed to do, we call that a nocturnal dip. So I'm all in favor, and I know we all are, Arthur, in reaching very quickly for home blood pressure monitoring when you're not sure whether to treat someone's high blood pressure in the office.
And it's even being used. It's even being used, as Dennis is pointing out. It's even being used to help guide. Do I need to intensify treatment? Let's say somebody's on treatment, and I want to know, are they really controlled? Because I just showed you data earlier tonight about how the better controlled the blood pressure is, the better the outcomes. So people have used ABPMs, those ambulatory blood pressure monitors, as a way to tell, is my patient really controlled? Did I achieve the goals that I was seeking?
Yeah. So this question, I think you alluded to this as well. Are we better off combining multiple blood pressure medications that have got different mechanisms with lower dosages than a single drug at a higher dose? Because clearly that's going to be an increased risk for side effects. So how do you feel about that?
Yeah, I'm in support of that. So I'm in the camp that would use multiple blood pressure medicines at lower doses. That's the argument for combination therapy. Trying to do it in a single pill, low doses, take advantage of different mechanisms of the blood pressure agents, and yet get the efficacy without side effect or minimize side effect. So we were all trained in an era where you just use one pill and push up the dose. And all we got, for the most part, was more side effects. We didn't get the additional lowering in many cases that we were seeking. Whereas combining multiple blood pressure medicines at lower doses not only can help with control, but can help with tolerability.
And I think it's just important to emphasize that many times we've got combinations in one pill. So a lot of times a diuretic is combined with one of the other agents. So you really only have to take one pill, but you're getting two agents. And sometimes you're taking two pills and you're getting four agents. So
Right.
It's not like you have polypharmacy. Next slide. We did the home blood pressure thing. I think we've covered that. So I like this question, Arthur, you know that, and you've alluded to non-pharmaceutical approaches. Are there holistic approaches to lowering blood pressure? So I think one of the things that you mentioned tonight, which is really important, is that vegetables and fruits are helpful in the DASH diet. So I thought I'd just let you know, what are the teas, for example, well, what are the vegetables, for example, that have been shown to lower blood pressure? And it was interesting in your slide, you actually had a glass of beet juice.
Mm-hmm.
So beets are very helpful in lowering blood pressure. Leafy green vegetables, celery, garlic. Why leafy green vegetables? Well, because they contain magnesium. Now, Arthur knows I'm a big magnesium fan. I actually wrote a book called Magnificent Magnesium. And magnesium can really help lower blood pressure, especially when it's only mildly elevated. It has many other benefits as well. But I've many times used magnesium in my practice, and I haven't had to start someone on a pharmaceutical drug where we have the potential for side effects. What about teas? There's certain teas that can lower blood pressure. So green tea, for example, black tea, hibiscus tea, chamomile, and hawthorn berry tea. Now, what about the caffeine content? Green tea does a better job than the other teas because it's got a lower caffeine content, like 29 milligrams for 8 ounces versus 47 for black tea. And coffee, this is an 8-ounce cup, so about 95 milligrams. And Japanese teas in general are actually like hojicha and sencha and matcha. They have even less caffeine. So just to let you know that if you drink a few cups of tea a day with low caffeine content, that can help with your blood pressure. So I'm thinking, and I'm going to do one of our talks on holistic approaches for cardiovascular prevention. And we'll talk about different supplements that are helpful for both lowering cholesterol and things like lowering your blood pressure. Next slide. Here we go. Why is my blood pressure so variable when I see different doctors in the same week? So very good question. We got many patients going to see 3 or 4 doctors a week, unfortunately, sometimes. And they get their blood pressure taken and it's different every time. And they get very confused as to what actually is my blood pressure. And of course, that makes a great case for home blood pressure monitoring. What do you think, Arthur?
I totally agree with you, Dennis. So that's where what we call a blood pressure log can be helpful. That's where that ambulatory blood pressure monitor can be helpful. When not always is it so straightforward. And that's the purpose of getting a log of what the home readings look like, or getting an ambulatory blood pressure monitor to see where really is my blood pressure when I'm not in a doctor's office, when I'm at home and I'm not by different doctors when I'm nervous. And that's that masked hypertension entity that we spoke about, or where people could have white coat where their blood pressure is high at a doctor, but not high when they're at home. So getting the log and really seeing the readings both at home and in office, not just at home, and using the ambulatory blood pressure monitor can be helpful to help distinguish those difficult situations.
Sorry, I'd just like to go back to the previous question about holistic approaches. I did mention, clearly the vegetables and fruits and magnesium, but let's not forget that holistic approaches also include exercise, lifestyle changes, stress management, yoga, meditation. So many, many different holistic approaches that are helpful for lowering blood pressure. Next slide. Is it acceptable to have a high blood pressure as you get older? And I think you answered that very well. Yes, your blood pressure is going to go higher, but we want to bring it down.
And that trial that I didn't show a slide of, but I alluded to it in one of the slides, that HIVET trial, I think really shattered that. The SHEP study is in the elderly. But in fact, treating blood pressure in the elderly leads to huge outcome benefits, less stroke, less heart failure, very, very meaningful to do. And of course, we don't want the person dizzy or lightheaded when they stand up, so we have to pay attention to side effects, but it doesn't mean we have to compromise on the goal of controlling blood pressure just based on age.
So that leads to our next question, which I think is a really good question. Should you have your blood pressure checked laying down and standing? And I'll tell you, in my own practice, I always did that. The first time I saw a patient, I think it's really important to see if they're orthostatic. But I'd love your commentary on how important that is, especially when we are putting patients on antihypertensive medications, and especially the elderly.
Yeah, I couldn't agree more. We try to do it in everyone. As Dennis called it, orthostatics, the difference in blood pressure between sitting and standing. There are certain diseases that are characteristically have this, what's known as autonomic insufficiency, where blood pressure can really drop when they stand up. So, for example, someone with Parkinson's disease is classically has that. And so if you're just treating a sitting and then the patient stands up and blood pressure plummets, you haven't helped that person. You've probably hurt them. And so we want to see their log of both sitting and standing pressures. And frankly, for some populations, we'll take the standing or the lower of the two as their real blood pressure to make sure that we're not causing too low blood pressure.
And especially, sometimes patients tell us that they're dizzy, and you take their blood pressure laying down, and you say, well, it's not your blood pressure. Meantime, when they stand up, you suddenly a significant drop in blood pressure, and you've got your answer as to why they're dizzy, and we have to cut back on the medication or increase their fluid intake. So I've got about 5 or 6 more questions, so I'm going to try to get to them, Arthur, and maybe we can just cut the answers back a little bit in terms of time. There's a couple of really good ones here that came in during your talk. With a diuretic, is there a recommendation for fluid intake? And that's such an important question because people get thirsty, and then you can basically minimize the impact of the diuretic. And what do you tell patients?
Yeah, we don't. The doses, people, I loosely call them a water pill. I would say that they're really a blood pressure agent. While they do get rid of salt and water, it's rare that they really cause major dehydration in the doses that we're using. I don't really ask when I'm prescribing a chlorthalidone or hydrochlorothiazide to ask people to drink more water just because I'm giving them that drug. I'm really using it as a blood pressure pill. And they should maintain normal fluid balance, but we don't go out of our way to ask them to drink more.
Yeah, we don't really change their fluid intake recommendation.
No.
And what you're really saying, it's not only about losing fluid that lowers the blood pressure with a diuretic.
That's correct. It's really getting rid of that salt.
Exactly.
Not just the water. Correct.
There's a question about tolerance and drug resistance to antihypertensives, like all drugs. Does that happen commonly, and how often do we have to increase the dose because of that?
Yeah. So again, that's an argument there for combinations. So if somebody thinks, well, I'm not responding, remember I pointed out at the beginning of the talk that the national guidelines talked about using 2 drugs right away in someone who has a very high blood pressure. Because if any single pill lowered your blood pressure too much, you wouldn't be able to tolerate it. You'd be dizzy or lightheaded. So doctors have tried increasingly to use 2 different pills and in low doses and combine them together to get different mechanisms. And usually that can help a lot in bringing blood pressure under control.
Great. Could you talk about the relationship between hypertension, high blood pressure, and atherosclerosis? So the question coming in here is there a direct effect on arterial hardening related to hypertension?
And it's a strong yes. There's an increase in Framingham. The famous Framingham study, hypertension was a major player in predicting heart disease. And I showed you data from SPRINT that people who had blood pressure better controlled had less heart disease. So strong yes to that question. Very strong link between artery disease and hypertension. It's up there with smoking and sugar as major causes of coronary disease.
So one of our favorite attendees who asks a lot of questions has another follow-up question about side effects that could be, I wouldn't call it a side effect, but he mentioned salmisartan can slow down plaque progression and reduce atherosclerosis. Do we have evidence for that? We know it can happen with statins. But are you aware of that? Mainly probably because that lowers blood pressure, because you just pointed out the relationship. But are there any antihypertensives that do a better job with that?
Yeah, I think that needs more study. But But as Dennis pointed out, the better control the blood pressure, the less cardiovascular events is very well established.
Okay. So now people who buying blood pressure monitors to use at home, there's a question about the wrist BP monitor. Is it accurate, and should we get ones that where we're using, the brachial cuff? And I'm very much in favor of that. I think the wrist ones can be inaccurate. I don't know how you feel.
I am too. We're strongly in favor of the arm ones over the wrist ones. We think they're more accurate and more reliable.
Okay. We've got a question here from somebody who says that they've got a family member with congestive heart failure, blood pressure in the up to 180/90. They've discontinued their blood pressure medications. And what should they do, and what will happen? And I know this is a tough question for us to answer, and except to say, please try to get them back on their medication. But what do you do when you've got somebody who's on polypharmacy, they're not taking their meds, blood pressure's going up? We got to get them back to their doctor, and we got to get them to understand the risk.
I couldn't agree more. That's HIVIT that we talked about, hypertension in the elderly. There's great data that lowering blood pressure reduces heart failure. And as I mentioned at the beginning, adherence, the data suggests that maybe as much as 1 in 2 people who are given blood pressure pills don't stay on them. Adherence alone is a really important concept here. And so that story that's being told in that question, very concerning, and we'd like to see the patient back on medication.
Okay. And because it's Women's Heart Health Month, there's a question from clearly one of our female patients, one of our female attendees, who says that women tend to be more emotional. Does that have an impact on their heart health? And if so, why?
Well, the Heart Association is definitely drawing attention to women's heart health, as Dennis alluded to at the beginning. And I mentioned in one of the earlier slides that as women cross menopause, blood pressures tend to rise. So there are some hormonal effects. But it's a group of patients that matters a lot to us, and we are just as concerned about controlling blood pressure in females as in males. And there is solid data that controlling them at every age group of women reduces risks. Of course, in the pregnancy population, it's a huge focus of gynecologists, OB-GYNs trying to avoid eclampsia and preeclampsia. And then in our population as well, better control for a female, less heart disease, less stroke, less heart failure. So no compromise in the female population.
Couldn't agree more. So there's a question here. I don't expect you to answer it. I'm going to refer this person to come and see you. They want to know, what is your favorite ACE inhibitor, favorite calcium channel blocker, your favorite alpha blocker? Sounds like a doctor asking this question. Favorite beta blocker, favorite diuretic, with and without patients with chronic kidney disease. So it's a question, and the reason I asked this question is just to let you know there's so many medications. I'd say there are tens of antihypertensive medications. And that's why it's so important to see physicians that understand all the different mechanisms. And we have hypertension specialists now, in fact, who are specialists in hypertension. There's hypertension board exams. But in our prevention center, we have excellent physicians who are all very clued up on how to treat high blood pressure. And my suggestion to that person is come and see one of our doctors. And I would highly recommend Dr. Schwartzbard, but it's not that easy to get an appointment for. It takes a few weeks because he's so popular and so excellent. Here's the number to our prevention center to see one of our physicians, Dr. Schwartzbard or one of the others. They're all outstanding. 212-263-4300. And there is our website address. So I'm going to thank you all for joining tonight. And let's remember, it's Women's Heart Health Month. Go Red for Women this Friday on February 7th. So please wear something red when you go to work or whatever you're doing, just to think about that, the importance of heart health in women. There's a fact that 1 in 2 men die from cardiovascular disease, and women are very, very close to that. Many people understand that women have increased risk of breast cancer. It's somewhere around of dying from breast cancer, somewhere around 1 in 8. So they know about breast cancer and they're very focused on getting mammograms. But it's so important for people to go out and get your blood pressure checked. Dr. Schwartzbard, you did an amazing job, as
Thank you,
expected.
Dennis.
Thank you so much. It was wonderful.
Thank you for having me.
really
Thank you,
are-
Anya.
We are privileged to have you in our center. Anya, thank you so much for your help. And everybody, we look forward to seeing you at our next webinar.
Good night, all.
Thanks, Arthur.
Thank you.
Brilliant.